Hello, this is the video lecture for Lily, chapters 3 and 4, Cultural Ethics and Legal Considerations. Here are your objectives to refer to. Some of these are just kind of key terms, and this first one is that. So, ethnopharmacology is the study of specific impact of cultural factors on patient drug response. Unfortunately, we have lack of a clarity in terms. Some of these terms are kind of interchangeable and they really don't mean the same thing, such as race and ethnicity and culture. Some cultural considerations to think about for medications include pharmacogenomics, and this is how we're finding that certain genetic traits affect drug response. For example, certain genetic makeups can be associated with people metabolizing drugs faster or slower, so it can affect things like drug toxicity. Adherence with therapy can have an impact of culture, environmental, and economic considerations, especially thinking about maybe people who have less access to care, pharmacokinetics and pharmacodynamics, and varying drug responses in different racial or ethnic groups. We have genetic testing that is not perfect for medications, but sometimes it can actually show uh, if a medicine might be more effective for a person based on their genetics. Some more things to think about in terms of culture and medications and treatment include health beliefs and practices. I know coming from the psychiatric background that I have, there are some cultures that really don't believe that mental illness is a legitimate thing. And so there's some stigma there. And so sometimes different cultures might not approve of taking medications or seeking treatment. And then we also need to think about people that come from more challenging backgrounds where there could be barriers to adequate care. That could be barriers to getting to care, barriers to being able to afford care, barriers to being able to get insurance coverage. And so these are things we need to be thinking about as we care for clients to make sure that we're advocating for them. Cultural assessment, we always need to think about if English is a second or third or fourth language, we need to think about if people need an interpreter. And I think you've probably already heard about this in other classes, but we should never have family members be an interpreter for many different reasons. So we need to get a medical um, certified interpreter. We can assess the types of treatments people are having, if they're taking any herbs, if they're using any folk remedies, either in the past or recently, any over-the-counter treatments, the impact of faith and practices. Some people might want to have um, a religious person there to help them make decisions. We can always think about incorporating that alongside with their treatment in the hospital. Social and community support. There are many cultures where there are multiple generations living together and where the family is is very involved in the care and or just a close-knit community. This helps us as well to access resources for people. If they're part of a strong community, then we can tap into that to help them to have better outcomes. And dietary habits. Thinking about when we're giving recommendations for diet, thinking about their preferences can be helpful. Drugs and legal considerations, and this is just big picture here, but the FDA, the Food and Drug Administration, their primary job is to protect the public. And this is the agency that decides if a medication can be available as a prescription or over the counter. They do not regulate herbs and supplements, however. And then the Drug Enforcement Agency, or the DEA, is especially concerned with potential drugs of abuse, and so things that we call controlled substances, which I'll talk a little bit later. And then we also need to make sure that we're considering our individual state laws, which sometimes can be complicated when we have different standards and laws state to state. So let's talk a little bit about how new drugs are developed. And again, this is guided by the Food and Drug Administration, the FDA, and the number one thing that the FDA is concerned with is safety and efficacy of drugs. And so before a medication is even begun to be tested on humans, there's preclinical testing, and then there are clinical studies. There's also investigational drug studies, and people that are in these studies need to make sure that they are aware they can quit these at any time. And when there's a medication that shows clear benefits and there's a great need, such as during COVID, we had expedited drug approval. So the full process, which I'll talk about on the next slide, takes several years, but there are times when, for the interest of the public, they might expedite. So for the drug approval process, like I said, people need to be able to quit at any time. And so giving informed consent, I like this picture, just this kind of shows what not to do. So if we are really not explaining things well, as you can see, it can be very confusing for patients to think about the right decision. And so to give truly informed consent in the most ethical way, it needs to be written in a language patient can understand. It needs to be witnessed, and nurses do not consent people for things, for either medications or for things like surgery or procedures, but we can act as a witness. And the patient needs to be deemed capable, have mental capacity to make a decision. And the main components of informed consent are talking about alternatives, risks, benefits, and potential harms. And for example, if there's a medication that there's a trial for and there are alternatives that are very safe, then we need to make sure the patient knows that. So now I'm going to talk briefly about the different phases of a clinical trial. I am going to put on here that we're thinking about the big picture here. And so please don't feel like you need to memorize all of these numbers here. And these will vary according to the trial as well. But the big thing to think about here is safety. And so in general, the phases are preclinical and then phases 1 through 4. And so preclinical, we're not even looking at human subjects. This is where they're doing research to see if the treatment appears to be useful and safe. Phase 1 is a small group of healthy volunteers, and we're just seeing the effects of the treatment, seeing side effects, and that sort of thing. And then phase 2 is a slightly larger group, and this is people that actually have the illness, and we're looking to see if there is efficacy, to see if the treatment is working, and to again look at the safety and adverse effects of the medication. Phase 3 is when we go to a larger group of people with the illness, and we continue to look at the benefit. We also are comparing the benefit with alternatives and continuing to monitor for safety. Phase 4 is actually when the medication is on the market. And so we're always continuing to look at safety, and we're looking at long-term effects. Sometimes after a medication is approved, it will actually have some serious effects that we might not realize initially. And so a black box warning is when this is something that has to go on the package for medication. And this is when there's a serious cautionary statement. This is required to be put on the label by the FDA. And this indicates the medication may have severe risks of adverse effects, including death. But the reason that the medication is still available is because the risks often are outweighed by the benefits. But it's something where it's for the consumer to be able to decide if they're willing to take those risks. And a drug recall is when a medication is out on the market, but with more and more subjects and being able to look over time when they see if a medication is actually not as safe as we hoped. So class 1 through 3, class 1 is the most severe. And so if you look here, class 1 would be if it's found that this medicine can cause severe health problems or death. Class 2 would be temporary problems or a slight threat. And then class 3 would be unlikely to cause any adverse health reaction. And so, again, thinking about big picture here, but just thinking about safety for patients and why it's important to continue to monitor the effects of medications. So the Controlled Substances Act, this is the DEA, so the Drug Enforcement Agency is the people that manage these types of substances. And just to kind of give some context, I'm a psychiatric nurse practitioner, and I actually have a DEA number, so I pay extra money to be able to prescribe these controlled substances, and that is for that extra oversight. And so these are medications that have a potential for abuse or dependence. And the 4 categories here that I have ranked, Schedule 1 would be the highest potential for abuse. And this is when there's no legitimate medical use. So this would be something like heroin, where high risk of abuse and never prescribed. And then Schedule 2 would be the highest potential for abuse that has medical use, and that would be things like stimulants. So things that are used for things like ADHD but could be abused. And then when we get to stages 3 and 4, there's a lowest risk. And so not stage 4, sorry. Schedule 4 would be the lowest potential for abuse. And this would be something like cough medicine that has dextroamphetamine. So the higher the schedule category, the highest risk for abuse, and the lower the schedule category, the lowest risk of abuse. But if it is a controlled substance, there is still a potential for it. So now let's think about nursing considerations related to drug therapy. So we always want to think about both the state and federal levels of legislation. And you always, let's say that you also want to think about the facility that you're at. You always want to make sure that you're following your state and federal guidelines, and not just referring to what your institution says is okay, because you need to think about if you're practicing within the right scope. And then we have each state has a Nurse Practice Act, and that describes the scope of nursing practice. It says what kind of education you have to have. It lists the standards of care and describes minimally safe nursing practice and helps to delineate between nursing practice and medical practice. So very important to understand your scope. There are some states as a RN or as an advanced practice nurse that vary very differently in what they allow nurses to do. And so especially if you're ever thinking about traveling or living in a different state, you really need to make sure that you understand the Nurse Practice Act for that state. Other places that we get guidelines include the American Nurses Association, or ANA. Like I said, your institutional policies and procedures, state and federal hospital licensing, uh, specific nurse practice acts, standards of practice, and HIPAA, which I'm sure you've heard a lot about HIPAA. And so we just need to make sure that we're thinking about following all of the regulations that we have to keep our patients safe, to protect their confidentiality, and to keep our license safe as well. Okay, so some ethical terms related to nursing practice. You probably heard these before, but just as kind of a recap. And so autonomy is when we're looking at the patients having the right to choose, make decisions for themselves for their care. And this is a huge thing that comes up in nursing care, where we can really be that voice for the patient to make sure that we're respecting their wishes. Beneficence is doing good, and so this is thinking about comfort, thinking about helping people to feel better and have optimal health. Confidentiality, where we're thinking about HIPAA, where we're not sharing any identifiable information about our patients. Justice is looking at fairness and equity in care, making sure that people have access to care. Non-maleficence, it's kind of the flip side of beneficence, and so it can be a little bit tricky, but non-maleficence is where we're thinking about not doing harm. And so this would be where we are advocating for patients to avoid any painful things, to avoid unnecessary procedures, that sort of thing, things that could be harmful or painful. And then veracity is telling the truth. And this can be hard. I'm thinking about things like cancer and things about when there's really difficult news that has to be given, making sure that we're advocating for patients and being truthful even when that is difficult. Tricky thing, which you'll get into more in things like mental health and human needs, is we also need to make sure we're staying in our correct practice, in our correct role, to make sure that we're not diagnosing patients. And so we want to be honest, but we also want to make sure that we're not going outside of our scope. All right, so if you're like me, then you might have some worries about ever being being sued or being found negligent. And so the terms, these are kind of interchangeable. Nursing malpractice or nursing negligence are really talking about the same thing. And the way that I learned it, I'm going to share with you, is that in order to be found negligent or guilty of malpractice, there have to be these 4 criteria that are met. So I'm just going to talk through these. So the first one is duty. And this means that you actually are, let's actually a little bit back. Let's say the nurse, because I really want you to feel confident that as long as you are doing your job and you're following the guidelines that you have and you are practicing safely, that I don't want you to be afraid of this happening. So you're by being systematic in your care and by going through the right steps and just being safe, then that is what protects you and documenting well. So let's just say the nurse, if there are accused of negligence, this would be where they would have to be assigned to be part of that patient's care. So if a nurse is on a unit and they never were assigned to a patient, then they could not be listed in a lawsuit. So the person would have to be assigned and have a duty to care for that person. Next, it would have to be found that they actually had a dereliction of duty or where they didn't do their job. So this could be something, let's say for medication, that the nurse is assigned to a patient and they had a medication ordered and the nurse did not give the medication. That would be an example of dereliction of duty. Maybe they had an IV and they didn't assess the IV and then there was a medication reaction. So something where the nurse did not do their expected care. But next, there also has to be documented um, and clear evidence that there is damage or harm. And so it could be that the nurse made a med error, they didn't do an assessment, but if there's no actual harm to the patient, that could be psychological or physical, then they can't be found guilty. And then lastly, and this can be the hardest thing to prove, there has to be a direct link between the action or inaction of the nurse and harm, and that's causation. So, one thing that I like to do for this, just to kind of practice it, is to actually write a scenario where maybe 3 out of 4 of those are met, or where all of them are met, just to try to conceptualize it. I'll just give an example right now while I'm talking. So let's say that I was talking about if a medication wasn't given. So let's say that a nurse was assigned to a patient and they had an antibiotic that was due. And let's say that they didn't give the antibiotic and it was, so they missed an entire dose of antibiotic and they didn't realize it. And then let's say the patient, their infection got worse because they didn't have the antibiotic and they had a severe infection and they had to have a higher level of care. So that would be where the nurse had a duty to that patient. They derelicted or did not do one of the tasks that was expected of them, and the patient did have some harm. Their infection got worse, and we know that antibiotics are what has to be given to treat an infection. And so hopefully that helps a little bit to kind of think about how those work together. Okay, and then we also have things to think about if we're never left on our own to do things ethically, especially when there's like a gray area. So one thing to always think about, and I've seen this on practice questions too, is if things are a gray area, it's always good to reach out and talk to somebody else, to talk to a charge nurse, talk to a provider. And when things are really tricky, then this is where they actually have like an ethics board at hospitals where it'll be not just one person's decision. But we do have some guidelines. So the ANA, American Nurse Association, there's a code of ethics for nurses that we can refer to. There's also an international version, International Council of Nurses Code of Ethics. And then something in terms that when we're thinking about drug trials, one thing that's an ethical consideration is the use of placebo. So it could be that if there's like a double blind trial, we do know that especially if a medication is beneficial, there are going to be people that are getting a placebo and hoping that they're going to have the drug and getting, we know these people that are put on these. Let's think about maybe a person with cancer. If they're hoping to have a benefit and they're given a placebo, then that is a difficult reality. So those are our ethical and cultural and legal considerations for medications. I have these study questions here for you to kind of think through. And I encourage you, like I said, to kind of think about some scenarios for these. Think about examples of things like autonomy or beneficence. And if you have any questions, please feel free to reach out. Thank you.